Adam, you got a haircut.
Just a little one.
Yeah, so did I. I was starting to get a little unruly.
Can you guys hear me okay?
I hear someone quiet.
You can't hear, can you hear me or no?
It's very quiet.
Okay, hold on. I'm gonna be right back. Can people hear me now or no?
I hear you.
Okay, cool. I guess I don't know what's up with my headphones. Are being weird. Okay, cool.
Hey, Laurie, we'll give everyone till 1:05.
Okay, yeah, cool.
He wanted to say hi to you, but he's talking.
Who?
Steve.
Steve Rogers. Wow, I haven't seen talk to his lady more than him. He never answers my texts. Tell him.
I always write back. Or my better half writes back.
Exactly. There you go.
That counts. That's teamwork.
That's why I always text her.
You're way better off.
She's
When you come
accountable.
to visit.
Is it snowing where everybody else is?
Started to snow here, Connecticut.
Yeah.
Yeah, it's snowing here. How about there, Laurie?
Yeah, we have like maybe like 2 inches on the ground or so far.
Laurie, is it snowing in New York?
Yeah, it's snowing. See if I can turn my picture. It's like, no, you can't really see out the window very well. It's pretty white out there, though.
It's beautiful here too.
Yeah, it's really nice. Although, kind of tired of the snow. It's too much snow on the streets now. Nowhere to park.
Laurie, you don't have to shovel a 35-yard driveway
That
every
is
time
true.
it snows.
Thank God. Thank God.
Yes, as I say to my fellows, first world problems, having to shovel my driveway to get my car out.
It's true, but it makes it tough to ever decide to want to move out of an apartment to somewhere with a driveway.
Yeah, then my kids turned the backyard into a bobsled run, so that's that.
Sounds cool.
Well, I must say to Henry and to Laurie, this is the hour that I look forward to the most every week. And I think I speak for many that because it's such a lovely group of like-minded people and talk about geeky things. So I'm excited.
Thanks, Lay. And that segues to the introduction for Laurie, who I miss dearly. So thank you for presenting today, Laurie. So Laurie's now at Columbia. She's going to be presenting a few cases, and I'll let her take it away. Go ahead, Laurie.
Okay, cool. So I have like 5 cases to go through that hopefully will be interesting, some more than others. And I'm curious for people's thoughts. Okay, so the first case, this was a fellows case, actually. I wasn't there. So some of these cases were not mine. I stole from people because they were cool. Others because I'm proud when fellows use ultrasound to find stuff. Because we love ultrasound. So anyways, this was a 16-year-old with a history of a recent pneumothorax, had been admitted to an outside hospital and had gotten a chest tube within the past like 3 weeks, and presented with chest pain and left shoulder pain for 1 day. When he came in, was afebrile, not in respiratory distress, heart rate was 98, and SATs were 97 on room air. And the physical exam was documented as they were well appearing. Their right side of their chest was clear, and on the left, they had some diminished breath sounds. Soft abdomen, otherwise unremarkable exam. So the fellow went into the room, and this is what they saw. Thoughts from anybody? Sometimes there's limited clips because it's all they got, or it's all that I could find on the machine. So on the right side, I mean, they had normal breath sounds. So on the right side, you can see normal, lung sliding with nice A lines and little Z lines. And then over here on the left, I think you guys can clearly see that at least it's suspicious for there's no lung sliding. It appears in that one lung field. So then they put M mode over it, and we had our classic, barcode sign. And they had diagnosed the pneumothorax before the kid even got a chest X-ray. So this kid, kind of a simple case, but I just want to share it because of the fellows again, but had a repeat spontaneous pneumothorax. This was the chest X-ray that was done after the ultrasound was done. Got put on 100% non-rebreather, and then ultimately was taken to the OR for a VATS and a blebectomy and a pleurectomy. And kid did fine and went home. So yay, fellas. Okay, this next case is interesting. I'm curious what your thoughts are. So this was a 15-year-old male, previously healthy, who presented with abdominal pain from GI clinic. They were referred to the ED with concern for a right lower quadrant abdominal mass. So the history was they had on and off abdominal pain for the past year. No significant changes in stooling, no blood in their stool, no change in PO. It sounds like they had overall like poor weight gain, but no actual noted weight loss, but were quite thin appearing on exam. So here's the initial exam when they came in. So they were afebrile. They were a little bit tacky. Remember, I think he was 15. Yeah. Blood pressure was fine and his SAT was fine. And you can see the exam here was notable for mainly just this right lower quadrant tender abdominal mass that was noted, no hepatomegaly or splenomegaly. So again, this wasn't my case. A fellow was there. So the fellow decided to take in the ultrasound to take a peek and look. This is the first clip. They were just looking at the bladder. So nothing too crazy here. Just gonna go through clip by clip. And this is the right lower quadrant. This was the first clip that they took. Anyone want to share thoughts at all? So, I mean, I think we all kind of see this, something that appears maybe blind ending. It looks like it's surrounded by, fluid. It looks edematous. It looks like there's, hyperechoic area surrounding it. Maybe, almost some cobblestoning looking like inflammation. So they took a measurement of it and measured 0.97 centimeters. So they were thinking maybe this was an appy. And they kept looking around the belly. So another right lower quadrant clip. They're more lateral now. And you can see there's just a lot of cobblestoning kind of superficially up in the top of the screen there. And then they went more, this is more medially to where you had initially seen that kind of blind ending pouch. And they saw this. And they put some flow on it, not really much. And then they kind of fanned through it. And they sent me these pictures via text. And we're like, what is this? So I'm curious what people think.
Laurie, Lei had a comment about cobblestoning intraperitoneal. If you want to expand on that.
Oh, sorry, I didn't hear what you said. What did you say?
Oh, I just said I don't know what intraperitoneal cobblestone is.
Oh, I didn't say intraperitoneal. Sorry, I saw just like it looked like in this picture, it just looked like superficial cobblestoning. Oh, I see what you're saying. You don't know what it means, I see, in intraperitoneal cobblestoning. Yeah, me either, really.
Yeah, I think it looks like it's underneath the fascial layer. So I think these are probably intraperitoneal, but
yeah,
I don't know what that is.
yeah.
I'm sure you'll tell us, but thanks.
Yeah, no, interesting. So when they sent me these pictures, like, my first thoughts were like, is this an appy with like a, abscess collection? Or, minus this kind of blind ending area over here, this like almost could be like a fake out to a intussusception because you kind of see some like layering. So I wasn't really sure. The kid was 15. The story didn't really fit. Kind of just talked about that. So they ended up getting a radiology ultrasound that was initially read as a perforated appendicitis, and surgery was consulted. But given the history of this kid's like year-long kind of belly pain, it didn't really fit with an appy. So they recommended getting an MRE. And they started the kid on Zosyn, and the MRE came back positive for showing essentially IBD with thickening of the cecum, the distal terminal ileum, and then a stricture. And then that large kind of inflammatory area that we saw that I thought maybe was like a abscess was actually just inflammation from IBD. That apparently is what it can look like on ultrasound. So it wasn't a collection at all, but just inflammation. No actual drainable collection. And he had a workup and ended up getting started on Remicade. He got a colonoscopy. He got diagnosed with Crohn's disease, and he was discharged home after getting some Remicade and stabilized. So kind of interesting. His labs I didn't share. His labs were normal. I don't know if anyone's ever seen anything like this before.
Or did you get a look at his? There was free fluid.
The clips I shared, they're in the pelvis like views of the bladder. It didn't look like there was any free fluid, but that was all that was there. It wasn't my case, so that was all the clips I saw.
So Laurie, hey, it's Adam. A couple weeks ago, I presented a couple of cases of IBD, and after reviewing a bunch of them, I really feel like they all kind of have a very similar pattern. And looking at this one, it kind of shares that exact same thing, where it's really like diffuse inflammation of the bowel walls. Like I've never seen bowel walls as thickened as I have in these IBD cases. And so I really think it's something that, we need to look at and recognize and be able to differentiate from appendicitis, where sure, you can get a colitis and you can get inflammatory changes, but that bowel wall, it doesn't get to be as thick. I would actually be curious if we went back and got a case series of all these things and got some measurements of either the TI or the cecum, whether we could have a numerical measurement that might be able to help us as a community differentiate these entities.
That would be interesting to look at. I think this is the only one I've ever seen, but if I'm happy to contribute, if it's something you want to look at, if anyone else has any too, could be cool.
And Adam, you also for that one kit that you follow when they were inpatient, they also ordered that specific lab that you said they usually order for IBD?
Yes, fecal calprotectin, which I never heard of, but I also do Journal Club for the Peds residents.
Yeah.
So, introduced me to that article a while back.
Yeah, GI always sends that here too. They did send fecal calprotectin on him, and it was elevated. It takes a couple days to come back. It's the only downside, but
not the bedside fecal calprotectin.
Yeah. Interesting. Cool.
I have one case that's sort of a similar, inflamed right lower quadrant, very thickened, sort of large bowel loops, bunch of nodes in sort of the area of hyperechoic fat, but could never find a definitive criminal appendix, and was read similarly rads as appy. And then the senior radiology attending the next day was nope, terminal sort of ileitis, and ended up being new diagnosis Crohn's with a much shorter prodromal clinical course that really matched better to appy, honestly.
Interesting. It's pretty cool. All right, cool. I will move on. Okay, this was a case. This is another case that a fellow had actually that they texted me some pictures. So it was a 7-year-old girl with a history of anemia and a VSD that was undergoing an IBD workup outpatient because she had been found to be anemic and had some weight loss. And she was sent into the ED for a workup and an admission to kind of just make her care a little bit quicker because she now had fever for the past 8 days. So her history had included 2 to 3 months of some weight loss, intermittent fevers, and a worsening anemia over that time that she had been referred to initially GI from her PMD. They had done some labs as workup and were planning on scoping her, but hadn't yet scoped her. I think her scope was scheduled in a couple weeks. So when she came into the ED, she was febrile, she was 38.2, she was tachy with stable blood pressure and normal SAT. The exam basically was notable just for tachycardia, a murmur that was noted to be 4 out of 6, a soft belly. And then on her skin exam, she had noted someone had noted this non-blanching, faint macular erythematous rash on her lower extremities. But normal cap refill, otherwise nothing notable on her exam. Nothing otherwise notable on her exam. So she initially had a workup in the ED that was notable for a normal white count. She was anemic to 7.2. You can see her MCV was 72. Her tick was a little up, and her inflammatory markers were markedly elevated. CRP was 126 and her ESR was 70. A chest x-ray was done and showed this concern for this right lower lobe opacity. And essentially there was uncertainty whether this was a new pneumonia or an old pneumonia because she had intermittent fevers over the past couple months, but it was decided to start her on ampicillin and admit her to the hospitalist service and consult GI and hematology the next day. So because our hospital never has any beds available, she was still in the ED 10 hours later. So on the next shift, she's awaiting a bed. The attending that came on was one of the POCUS people. So she decided just to look to see if this actually looked like a pneumonia. You can see here, we're looking at her lungs, and she clearly had an opacity, in her right lower lobe. You can see, clear air bronchograms, kind of a small effusion, and they felt good about continuing the ampicillin. although I guess they spoke to GI about these findings and, weren't really sure what was going on. And, she hadn't gotten admitted yet. So they asked for a CT chest, abdomen, pelvis because of the markedly elevated inflammatory markers, just looking for, I think, an abscess in the belly or something else causing these fevers and high inflammatory markers. So there was another change of shift. And by that time, the CT chest had come back and she had confirmed the right lower lobe pneumonia, otherwise had a normal abdomen pelvis CT. And the fellow that was on decided to do point of care ultrasound because the child was still markedly tachycardic to the 150s and not febrile anymore. These were the pictures that they got. So here's their subxiphoid. And then here is their peristernal long. So curious if anyone has any thoughts on this.
Looks like something in the right ventricle.
Echo.
Yeah. So yeah, exactly what they were concerned about, these kind of hyperechoic lesions in the right ventricle. And here's their short, and you can still see them over here in the right ventricle. And then the the apical 40, couldn't really make them out as well, but you can kind of still see something over in the RV there. So they were obviously concerned for, either a clot or, some type of vegetation like endocarditis. So they consulted cardiology, and the child got a formal echo, which confirmed they did indeed have endocarditis. Got started on Vanc and Gent, ended up getting a blood culture sent because one hadn't been sent apparently, and it grew strep from both peripheral cultures. And the child ended up having like a prolonged admission and ended up eventually going a tricuspid valve vagectomy and VSD repair. That was probably the cause of her endocarditis. So curious if anyone's ever seen anything like this on ultrasound. I've never seen on bedside vegetations or even something like clot that's attached to the ventricle. I thought it was pretty cool, especially if the fellow found it again.
So I joke, but if you're on Twitter and you follow some of the film ultrasound stuff, it's like every day that somebody on the adult world is posting, mobile clots on the right side and, all some little cute little things because it looks like a little ball bouncing around all over the place. I've only had one patient that we didn't catch in the ED. I only had them up in the PICU that had vegetations on the valve. What was this kid had a history?
No, the only history was they had an unrepaired VSD that was being watched by cards, but otherwise was a healthy child that just had this weight loss for 3 months and intermittent fevers and was going this IBD workup. Which, I mean, this kid probably would have gotten admitted and eventually gotten an echo, but I definitely think this POCUS in the ED probably, sped up her care and definitely made changes in her care.
Yeah, I've seen quite a few vegetations on rheumatic heart valves overseas. It's a rare occasion that we see it in, at least I see it in New Haven, Connecticut. We often get these letters from our cardiologists saying, prophylaxis, SBE prophylaxis not warranted or unnecessary. I think all of our patients have that on their chart now. So we don't think about bacterial endocarditis, even in these unrepaired or post-op patient. I guess this is a lesson for us that it does still happen, even without medical care in our tertiary care centers.
Lord, do you think that if you were there, you would scan his heart? I mean, that's what I'm trying to think. If he would have presented the same way, if I would have scanned his heart immediately.
Just lost sound. Sorry, I don't know what's going on.
I'm sorry. Can you guys hear me? I'm really sorry. I'm having some sound issues. Yeah, sorry. For some reason it's switching. I usually use my headphones and they keep switching back and forth my sound for some reason. So anyways, Leigh, I heard you say that you had seen this, and we don't we don't really think about it as much in this population anymore. But yeah, it is interesting because I guess this is a reminder that we still should consider it.
And Laurie, what I was thinking is like, I don't know if I would have, if you were like the, you know, the initial person that evaluated, would you have checked his heart? I don't know if I would have checked his heart either. Looking back.
No, I thought about that, especially because like they were febrile and tacky. Who knows? Like hindsight's 2020. Probably not. I mean, they had a pneumonia. Like it definitely looked like a pneumonia. I probably wouldn't have. I don't know. I didn't actually see the child. It sounded like she was very stable appearing. So
You said she was there for like several shift changes on the ED.
yeah, she was
watch,
in the ED for like
So that's-
27 or 30
those are
hours.
hopefully the exception to where, you know, we get a diagnosis or a reasonable diagnosis and pass off, and then, you know, a day or two later when they're not responding, sort of it's a reassessment. Unfortunately, that day or two later was still in your unit.
True. Yeah, that's a good point. That's a good point. Yeah. She actually, I think she was actually in the ED even longer, like 35 hours. Now I think about it. So
Just to follow up on that question, Laurie, say your fellow just saw a tachycardic heart, you know, presumably that was from some sort of sepsis pathophysiology. And most children with SBE, we don't see vegetations. Do you think his or her, I guess, her clinical course would have been different?
if they didn't
Yeah,
see the
would
vegetation,
they not have considered SBE or BE, I guess, as a possible?
yeah.
Yeah.
I know. I do wonder that because a blood culture hadn't been sent at that point, which is interesting because I think the initial history maybe was taken wrong. Like there was this history of 3 days of fever, but in the context of 8 days of fever, you know, if that had grown out strep, I think people definitely would have gotten an echo. But I don't know I don't know what the floor would have done if they thought they were just treating this pneumonia. I think that in this particular case, from reading the notes, the child probably would have ended up undergoing like a colonoscopy, endoscopy. That probably would have been normal.
Yeah, don't assume this kid would have gotten an echo. You should like totally think that you saved this guy's life. Seriously. I mean,
yeah, I definitely think it sped up care at the least. Like, you know, definitely changed
Sure.
management.
I agree with Adam. I mean, that's what I'm saying. I think we often don't give ourselves credit and not ourselves best champions. I think Antonio's not here to toot our horns, but I do think sometimes we really improve patients' outcomes by, you know, thinking, you know, using a tool that's not always readily available. Yeah, in some ways we were lucky in the sense you saw the vegetations that were actionable, but you know, I still think this is a good example of where you've made a difference for the better.
Yeah, definitely an interesting case for sure. So, and I think like in this particular case, I mean, or in these cases, you know, when fellows see these things, they do get very excited that, you know, it did change something. So this fellow in particular is a third year and now has like changed gung-ho into like, they're doing a lot of ultrasound now, which it's exciting. Like one case that can really, you know, pique someone's interest and like they finally see, you know, how it can change management and its use in every patient really. So, okay, cool. I will move on. So this next case was a 6-month-old who presented with a neck mass for the past month. The mom said that the baby, the mass had been, enlarging over the past several days. There was a little bit of mild redness over the area, but no fevers, not really fussy, still like eating, drinking well. So she came to ED. So initial exam, the child was afebrile, normal, otherwise normal vital signs. And you can see the exam was mainly just notable for this 4-centimeter mobile fluctuant, like midline mass that was non-tender per the examiner. So this was the first clip that was obtained. So they're, you know, transverse over this area in the neck. Curious what people think. I mean, so like you can like see this kind of
thyroglosal.
Yeah, sorry. I think you said thyroglosal duct.
It says
and
looks too lateral for that.
Oh, look lateral. I see what you're saying. So you know, this is this actually did turn out to be a thyroglossal duct cyst. Like, so, you know, it's like well circumscribed and kind of has this like posterior acoustic enhancement and these kind of mixed bright echoes within. Here's the sagittal view. And so after they did this, they ended up consulting ENT. They ended up getting a radiology ultrasound as well that confirmed a thyroglossal duct cyst that they said they couldn't rule out infection. Here it is measured. So they sent this child home on Keflex, and the child actually returned a week later and had finished the Keflex, but still had some like enlarging area after a few days after finishing the Keflex, and there was actually a collection measured that at that point within the thyroglossal duct, and they got admitted at that point, and then they ended up going to the OR and getting it drained, which I thought was interesting because I feel like they usually don't take care of these until, you know, the acute infection is over. So the notes were a little difficult to peruse through in terms of what actually happened because they lacked some details. But I'm assuming it was just growing in size from what it looked like, and that's why they decided to take it to the OR and drain it. And that was a picture of the kid in the ED from what they saw on the first visit. There's no pictures or there was no POCUS on the repeat visit. So, have you guys seen these before? Adam, have you seen them? You seem to recognize it right away.
Yeah, usually they're like within like a little tendinous sheath, and so, you know, when the kid does any of its tongue motions, you can actually see it kind of bounce a little bit up and down.
Yeah.
But from that initial image that you had, you said that was a transverse view.
That's what it's labeled as. This was not my image, so I'm not sure, but it's labeled as that. Yeah.
It looks like it because it looks like you have, you know, the lateral lobe of the thyroid, and
that's a good point, actually. Yeah.
So, you know, it seemed like underneath the Z would be like the most anterior part of the neck, and this thing is
like top bottom. Yeah, it actually even looks that way from the tissue planes. Yeah. So kind of interesting. I've obviously seen these, but I've never, I don't know that I've ever actually ultrasounded one, which is kind of fun.
Yeah, my favorite one was an 18-year-old that we diagnosed, and everybody else was in disbelief that they had gotten that old and hadn't been diagnosed as of yet, but had a couple of recurrent episodes that seemingly went away with pediatrician's amoxicillin.
Wow, 18. That's impressive. Cool. All right. Well, this is the last case. So this was a 13-year-old who had no past medical history, who presented with chest pain, dizziness, and difficulty breathing. They said that they had been having these worsening symptoms over the past month, but had acutely worsened on the day of their presentation to the emergency department. No fevers and hadn't had any recent illness. So these were their initial vital signs. They were afebrile, they were tachypnic and tachy, and hypoxic with a pretty normal blood pressure. And this was the initial note. She was noted to be in distress. She was tachy and in respiratory distress. So initially, they went in and they did a lung POCUS because they were looking for a pneumothorax given she was hypoxic and in distress. And there was no pneumo on lung ultrasound, so they decided to look at her heart. So here's the peristernal long. I don't know if anyone has any thoughts on this particular view. I'll give you the
Right
next.
heart seems generous there.
Yeah, totally.
It's sort of bulging into the LV.
Yeah, exactly. And then here's the peristernal short, and you're seeing like exactly that. So, you know, you're getting this D sign with kind of dilated RV and flattening of the septum. So obviously they were concerned for a PE given her appearance and this ultrasound. So she went to, here's the other views. They could only get a subxiphoid, and then she really couldn't tolerate being lied flat because of her distress. So couldn't really look at the IVC and couldn't get a good apical 4. So she ended up going and getting a CTA of her chest, and she had bilateral large PEs in both pulmonary arteries, and in fact had like a right middle lobe pulmonary infarct. Also on that CT, she was noted to have abdominal heterotaxy and polysplenia and a transverse liver, which is interesting. She didn't know this. She was an otherwise healthy child, although it doesn't seem like there's any relation to this per the notes that I perused in terms of being hypercoagulable. So in the ED, she was initially put on 10 liters and her stats were initially in the low 90s. And then she just kind of continued to desaturate and was in severe distress. So she ended up getting intubated for hypoxia and started on a heparin drip. 6 days later, it looks like in the ICU, she had, from the notes I found, worsening respiratory distress and had an ECMO console at one point, but was never actually started on ECMO, and ended up going to the cath lab for right heart cath and a thrombectomy. She ended up having a negative thrombophilia workup and including negative COVID PCR and serology. And she ended up recovering and was discharged home on Coumadin. But I just thought this was a really cool case because, I mean, in this case, I think POCUS 100% changed her acute management and expedited her care. Although she was sick and probably would have gotten all this anyways, they knew in the first like 5 minutes of her arrival that she probably had a PE. So I know, Julie, you presented a patient like this, I think a couple months ago.
I know, and you know what, for that patient, we did not have the serologies, but I sort of, I rationalized that it must have been the, beginning of COVID, insidiously infiltrating into our community, and like it must have been, but I guess this one happened spontaneously, and we don't know if the other one happened spontaneously too.
Yeah, it's kind of crazy. Like I've seen a number of PEs lately, and it's I don't know, it's frightening sometimes to think about in terms of these healthy children who, she wasn't even on birth control, had no real setup, and a 13-year-old,
Yeah, I agree, especially because the evidence shows that we really don't have don't have that great ways to screen for it.
Exactly. Yeah, totally agree.
I just had a completely healthy 14-year-old male with a pretty sizable DVT in his pops and completely negative workup.
Wow, that's crazy. That's so
including a D-dimer, Will?
The dimer was elevated from the DVT, but the coagular workup, serology, everything else from a heme standpoint to, as to why was negative.
So interesting. Something in the air, I don't know, or they had COVID and they just they don't have antibodies now. I don't know, although I have no idea. I'm just speculating. That's all I got though. It's my cat checking out the snow.
Those were great cases, Laurie. Thank you.
Yeah, no problem.
Thanks, Laurie.
Thanks for listening. Cool.
So next week we'll have Erica Constantine presenting. So looking forward to seeing everyone next week. And Laurie, again, thank you so much.
Yeah, no problem. Thanks guys. Nice to see everybody.
Thank you.
Bye.
Thanks, everyone.